Hi there to those who've just joined us. This is Fiona from AAMAC, and we're just going to give it a few more minutes before we get going with the webinar.
Oh, and that's Jasper. He didn't get the listen only mode notice. I'll try and keep him quiet.
So hello to those who've just joined us. We're just waiting for a few more people to get online, and then we'll get started with the webinar. Hello everyone. My name's Fiona Lewis, and I'm pleased to welcome you to this webinar hosted by AAMAC. AAMAC is a leading funder of research into bone marrow failure diseases in Canada, and our organization supports patients and caregivers across the country who are living with aplastic anemia, myelodysplastic syndrome, and PNH. I'm the patient support liaison for BC and Alberta. And I invite you to visit our website to find out more about our services across Canada. I'm pleased to introduce our speaker for today's webinar regarding the therapeutic potential of cannabis. Reanne Booker is an oncology and palliative care nurse practitioner in Calgary. She's worked in cancer care for over 20 years, and she currently works with the palliative care consult team at Foothills Medical Center, and is also working on her PhD in nursing through the University of Victoria. The focus of her research is on the integration of palliative care in oncology. Her clinical and research interests include symptom management, sexual health and cancer, the integration of palliative care in oncology, and medical cannabis in cancer care. Reanne has 2 daughters and 2 dogs, and just told me she has a new puppy who's, I think, with her today. So we're going to have lots of time for questions at the end of Reanne's presentation. I ask that you type any questions you have into the chat window on the right hand of your screen, and then I'll read out the questions for Reanne to answer. We are recording the webinar, and we will be making it available on our website later in the week, probably. So with that, I will turn it over to Reanne, and I will mute my line.
Thanks very much, Fiona. And as Fiona mentioned, I have a very playful, active little miniature Dachshund who is climbing all over me right now. So I'll do my best to try and keep him quiet and avoid any interruptions as much as I can. So again, thanks very much for having me today to speak about medical cannabis. It's a topic that's garnered quite a bit of attention over the years, particularly since cannabis became legal in Canada a couple years ago. And I just wanted to say, to start out with, that this presentation doesn't constitute medical advice. And I always encourage people to check with their physicians and healthcare team before making any changes to their medical treatment or their medical care of any kind. And let's see, I need to advance the slides forward. There we go. So just to state that I don't have any conflict of interest with any pharmaceutical or medical supply companies. I've received a number of different scholarships and funding for my PhD studies, including one award that I'm very proud to have received now 2 years in a row, the Liz Lemire Memorial Scholarship. Liz was a teacher from Calgary, and she had aplastic anemia, and she passed away unfortunately in 2008. And AAMAC, she did a lot of volunteering for AAMAC, and AAMAC has been very helpful in supporting ongoing nursing education, and I just wanted to acknowledge that as well. Okay, so continuing on here. So today I want to talk about the different types of cannabis that are available. So the types, the strains, formulations, routes of administration, and the various different medical indications for cannabis use. And then also to talk about some safety concerns, so side effects and contraindications and precautions and cautions. So as I mentioned, cannabis became legal a couple years ago, and this is just kind of a broad overview, and this was from 2019, second quarter data, showing the usage across the country. And you can see Alberta is kind of leading the pack there in some ways. The Northwest Territories, Iqaluit as well, have pretty high use compared to the rest of the country. And we're seeing, again, this is from 2019, that it's typically the younger age groups that are using cannabis. It's less common among seniors than it is in other groups, but draw your attention to this, the graph on the right here that shows that cannabis consumption among seniors has been growing, and it is accelerating at a much faster pace than it has been among other age groups. And it's important to note that more than 1/4 of seniors who use cannabis are new users to cannabis, so meaning they hadn't used cannabis in the past. Again, this is kind of looking at the indications or the reasons why people are using cannabis. So breaking it down to medical, with or without a medical document or prescription, non-medical, or both medical and non-medical usage. And you can see again in the older age group that it's mostly medical usage. And in the younger age group, it's more non-medical use. And then the groups in between, it's a combination of both. Now we're seeing with the pandemic that cannabis sales have increased, and this is just data up until March this year. But you can see here that there was a trend in increased spending on cannabis that began in March, coinciding with the onset of the pandemic in Canada. Similarly, looking at adult use cannabis sales by month, you can also see increased usage or sales, I should say. Doesn't always necessarily equate to increased usage, but increased sales increasing here towards February and March of this year. And there have been some studies done, and one done by the Canadian Centre on Substance Use and Addiction found a 25% that 25% of Canadians between the ages of 35 and 54 reported an increase in how much they drank during the initial phases of isolation. And they said that their increased use was linked to a lack of regular schedule, boredom, and stress associated with being isolated. Again, the same organization produced an infographic and some information on their website looking at the reasons why or the conditions around COVID-19 leading people to increased alcohol and cannabis use. So you can see here feeling stress and anxiety from the pandemic itself and also the economic impacts. The blurring of daily and weekly routines because of the closing of non-essential workplaces and people working from home. Feelings of social isolation and loneliness due to the physical distancing, and then stockpiling, so people having more alcohol and cannabis in the home, just anticipating that they may not be able to access it later, perhaps, and stockpiling it, so it's a little bit more readily available in the home. So to speak briefly here, and this is a relatively complicated slide, but the physiology of how cannabis works, I guess, is quite complicated. And so humans have an cannabinoid system, and it's that's short form for endogenous cannabinoid system, and that's composed of all cannabinoid receptors, the things that bind to those receptors, and those are called ligands, second messengers, and the degradation pathways. And so it's quite complicated, but just to make the point that cannabinoid receptors are ubiquitous, meaning they're all over the body, and they have an estimated 10-to-1 preponderance over opioid receptors in humans. So they're quite plentiful throughout the body. And we know that there are different types of receptors, and CB1 receptors are mostly located on neural tissue in the central nervous system, and CB2 receptors are mostly located on immune tissues. And generally speaking, CB1 signaling is responsible for neuromodulatory activities, and CB2 signaling is responsible for mediating immunomodulatory activities. So kind of complicated. We also have some naturally occurring endocannabinoids in our system. So that's anandamide and 2-AG. And so these molecules can activate the cannabinoid receptors and cause responses in the body. And then we also have exogenous or out of the body cannabinoids. So we have the pharmaceutical preparations, which I'll speak about in a minute, or the botanically sourced, and that would be the plant-based cannabis. And they can bind to these receptors and exert effects as well. So quite complicated. And here's just a little bit more about the receptors and how these ligands or these substances will bind to the receptors. So again, we know that we know more about CB1 and CB2 than the other receptors in the bodies, but we do know that they're probably much more complicated receptors and things like that than we know about at this time. We do know that THC can bind to CB1. It's what's called a partial agonist, and when it binds to CB1, it activates that receptor, and that can impact pain, appetite, digestion, emotions, and those kinds of things. And CB2, by contrast, binds. It's what's called a negative allosteric modulator of CB1. It's a partial antagonist of CB1, and it's a weak inverse agonist of CB2. So it's a little bit more complicated, CBD. We don't really know exactly what it does. And there's some thought that it also might impact serotonin. So it's really quite complicated in terms of what CBD does. But we do know that it can impact receptors for sure, and the responses thereafter of the binding. And so we know also that CBD, even though it only weakly binds to these receptors, it can antagonize or oppose the effects of THC. So that's important when we talk about trying to manage those unwanted side effects that come with THC. But to make the point that this is all still quite elementary in terms of our understanding, and the understanding of how this all works is very much evolving. There was a drug called rimonabant, and it had been approved for use, I believe, in the European Union in 2006, but it was discontinued because it caused significant side effects. So it was actually a cannabinoid receptor subtype 1 antagonist, an inverse agonist, and it was initially marketed and approved to help with obesity, so it was an anti-obesity drug. But it ended up causing profound depression, anxiety, nausea, and suicidality, and so it was ultimately discontinued. So sometimes when we block receptors, we learn more about what they do, and that was the case with that particular drug, is that it blocked the CB1 receptor, and it led to all these downstream negative side effects. So again, just to emphasize that the whole cannabinoid system is quite complicated. And when we talk about cannabis itself, cannabis is a plant. It's actually an annual, and it contains hundreds of different constituents and over 100 cannabinoids. The most well-known cannabinoids are THC and CBD. Those are the ones we talk about all the time. But there are a number of other important cannabinoids as well that we're starting to learn more about. Terpenes and flavonoids are quite important as we're learning. And then, of course, as I mentioned earlier, we've got the synthetic or human-made cannabinoids as well. So some of these are prescription medications that are available in Canada. So again, very complicated. Most people probably have heard about cannabis or marijuana or weed, and sometimes you might hear about indica or sativa. And there's some debate here if cannabis is one species or a number of different species. So people have described cannabis indica, cannabis sativa, cannabis ruderalis, or a mix. It's probably not important to know the differences between those, but just more so to know what is in the cannabis you're using, particularly in terms of THC and CBD content. So you'll also have a strain associated. Okay, now my dog's squeaking his toy, I'm sorry. You'll also have a strain associated with the cannabis, and that's the name. So kind of like how, you go to buy beer or wine, and there's different beer or wine names and things like that. There's different names for different types of cannabis in the retail market. So things like this example I'm showing here, honeydew, there's one called Girl Scout cookies, and different names like that. And those names, as I said, are reflective of the grower's name sometime, where the cannabis came from or the attributes. Sometimes they just come up with funny names because they think it'll help market the cannabis similarly to how we market alcohol. So again, probably less important to know all about those details and more important to know what is actually in the cannabis you're using, particularly as related to the THC and CBD content. So formulations, again, to complicate things, cannabis is available in a whole bunch of different formulations. So again, a lot of people know about the flower, the buds, and that's the cannabis right there. You can get it milled, so it's or ground to a very fine powder. It's available as oils, tinctures, edibles, beverages, topicals that you can rub on your skin, some illegal synthetics that people make in their own home laboratories and things like that that are not safe to use because they have other ingredients and constituents that can be harmful. So things like spice and K2 are not recommended to be used because they can be dangerous. And then, as I mentioned, the pharmaceutical products. And there's a whole bunch of other things that are coming on the market as well now too. So lubricants, patches, gum, intranasal sprays, you name it. Because cannabinoids are very lipophilic or fat-loving, they don't dissolve in water. They have low water solubility. And so to get them into your body, you need to do something to extract that THC and CBD out of the plant. And typically that's done either through combustion, so smoking, or can also be done through extracting through fats, oils, or polar solvents, things like ethanol and different solvents. And so we know that absorption is variable depending on the route of administration, and the bioavailability is also variable. And I'll get into a little bit more about each of these routes. We know that, again, smoking is probably the route that people are most familiar with, and vaporizing, again, similar to the vape pens and e-cigarettes and things like that. Dabbing is a particular route of administration that involves the inhalation of flash vaporized cannabis concentrates. So usually a modified water pipe is used where the bowl is replaced with a nail to be heated with a blowtorch, and that's actually very dangerous and can cause severe injury if accidents and things like that happen with the equipment. Again, the pharmaceutical products that we have on the market here in Canada, we've got a product called Sativex or nabiximols, and that is a combination of THC and CBD in roughly equivalent proportions. And this, it's a liquid, it's this guy right here, and it does contain ethanol and some other non-medicinal ingredients, and can be helpful for some people with chronic pain issues, advanced cancer, and other indications that I'll get into in a few minutes. And then we have the other prescription or pharmaceutical product, Sesamet or Nabilone, that is a synthetic THC analog and is a pill. It's this guy right here. In the States, they have Epidiolex, and that's for seizure disorders, and that is a CBD containing product. So we know from anecdotal evidence and from studies as well that there's something called the entourage effect, where the cannabis plant, because it's got so many more components other than just THC and CBD, the terpenes, the flavonoids, and things like that all exert their own effects. And there's a belief that this interaction between the different compounds of cannabis can produce what's called the entourage effect. And so some people feel that the plant-based cannabis works better or may have more therapeutic potential than the prescription products alone, just because those prescription or pharmaceutical products don't have all those other constituents like the terpenes and the flavonoids. They usually just have in the case of Sativex, it's THC and CBD. In the case of Nabilone, it's just THC alone. So again, to speak a little bit more about the different routes. So again, as I mentioned, smoking is the most common route of administration, but is not recommended. So the process of decarboxylation, which occurs through thermal treatment, so that's heating or combustion, that generates the pharmacologically active forms of THC, CBD, and the other constituents. And combustion at high temperatures, while it's effective for kind of releasing the THC and CBD, it also produces toxic byproducts, such as tar, polycyclic aromatic hydrocarbons, carbon monoxide, and ammonia. So chronic use by inhalation, it's associated with respiratory symptoms, not necessarily increased risk of COPD or lung cancer, unless the person's also smoking tobacco. But there can be lung damage and issues with respiratory problems. The other issue with inhalation is that you can lose up to 50% of the cannabis, the THC or CBD, by side stream smoke. Now, vaporizing was initially thought to be less harmful than smoking, and vaporizing heats the cannabis to a lower temperature, so there's reduced carbon monoxide, but there still may be those harmful polycyclic aromatic hydrocarbons, and so it can still be potentially harmful. And we know from recent reports, particularly by the FDA and reports in the States, that there is something called e-cigarette vaping associated lung injury, or EVALI, and associated with e-cigarettes that may just only have tobacco, or may be associated with e-cigarettes that have THC vaping products being used as well. And it's thought to be related particularly to the use of a product in the e-cigarette called vitamin E acetate. But at any rate, this is a potentially harmful injury that can happen with the use of vaping or e-cigarettes. So it's something to be very cautious about. And again, as healthcare providers, we would not recommend smoking or vaping cannabis. In Israel, they're doing a lot of studies on cannabis for medicinal purposes in Israel for whatever reason, and they're looking at something almost like a metered dose inhaler, like we would use for asthma or COPD, to deliver a safe dose and I guess a very controlled dose of either THC or CBD or combination. And so that's under study right now in Israel. Now with oral consumption, and this is something that is definitely growing in popularity, particularly since edibles became legal for sale and purchase late last year. And so oral consumption may be desirable because you don't have those harmful side effects that you get with smoking. But the difficulty with oral consumption is with the metabolizing of the THC and CBD or the cannabis. It's difficult to predict response, and that makes it harder to titrate or adjust. And so, you know, if you're going to take a cookie or a brownie or a gummy or something like that, it can take upwards of 45 minutes to 2 hours, and it's quite variable per person and per product even. So you may not feel the effects for up to 2 hours. And so that sometimes leads people to take a second cookie or a second gummy, and that can potentially lead to inadvertent overdose and taking too much or more than was intended. So again, these products for oral consumption are available in tinctures or ingestible oils or capsules that have the oil in them, or edibles, such as gummies or cookies. And you can make your own cookies, or you can purchase them now. You can purchase these products from the licensed cannabis shops and that across the country. Yeah, I was going to say one other thing about that. There can be, as I mentioned, the delayed onset of activity, and then poor bioavailability. So that can range, and that has to do with, again, the metabolizing of the product, and bioavailability can be as low as 2% or as high as 20%. So it's quite variable as well. And this is just a chart that Health Canada released in anticipation of the edible cannabis and extracts and things being approved last fall. Lots of different information there. And now we'll start to see, I'm sure, cannabis-infused wine, beer, spirits, which is kind of an interesting thing to consider. But again, we know that cannabis is not very water soluble. And so you need something that's got a very high concentration of alcohol to be able to extract the cannabinoids out of the bud. So you need about 40 to 50% alcohol that's 40 to 50% in strength. And typically beers around 5% or so, and wines between 12 to 20% alcohol concentration. And so if you're looking at cannabis-infused wine or beer, it's not likely to be very effective, particularly for medical purposes. And there's an author, he's a palliative care physician, who's written a book called Stoned, David Casseret, and he drank wine that allegedly had 1,000 grams of marijuana in it. And sorry, I think it was 1,000. Yeah, it was 1,000 grams of marijuana in the wine, infused in the wine, and he drank about a gram's worth, but he had no effects other than a pretty bad hangover the next day. And again, that's because the THC and CBD are not water soluble. So basically, he was just drinking something that had, you know, been steeped, or the cannabis bud had been steeped in this wine, but didn't really, it wasn't effective at releasing the THC or CBD. So his suggestion is if you want to have THC or CBD infused alcohol, you would need to have something in the neighborhood of 40% or so. And he suggests in his book, you could try this with vodka, leave it in for a couple weeks, and then you would be able to probably have some extraction of the THC and CBD. It probably wouldn't taste very good though. And the other potential option is you can use fat. And so the long carbon chains in fat can bind to THC and CBD and pull them out of the bud. And again, the recommendation would be to cut up the buds or grind them to maximize the surface area that will be exposed to the oil or butter. And you can heat cannabis in oil or clarified butter, and then the cannabinoids will seep out of the bud. And once the mixture cools, you can strain it, and then you could use that butter for baking or cooking and that kind of thing, and it would be infused with some THC or CBD. Topicals, again, we see topicals used for treating local inflammation. There's also lubricants, face creams, salves, different things like that. Again, we know that THC and CBD are large molecules and they have difficulty permeating the skin. And so to rub a THC or CBD containing cream on your skin probably won't give you too much bang for your buck. There are some companies that are looking at permeation enhancers, and this might help the CBD to penetrate the skin and might be more efficacious in terms of helping with local inflammation. But as of right now, we don't have any of these products on the market in Canada. So again, my apologies, more complicating science here to talk about, but just showing the differences between the various routes of administration and the impact on the body and that. So if you're smoking cannabis, the onset of action, the effectiveness will happen usually within 5 to 10 minutes. And the side effects or the effects of the cannabis will last for about 2 to 4 hours. It's pretty easy to titrate, meaning you can take a few puffs and you'll know pretty quickly if it's helping with your pain or whatever the medical issue is. Similarly, vaporizing would be the same kind of experience in terms of how quickly it starts to work and how long it lasts. As I mentioned, the oral route is variable, so it can, before it kicks in, it can be up to 2 to 4 hours before you notice any effects, and then it can hang around and cause effects in your body for up to 24 hours. Usually it's only about 6 to 8 hours, but you can see how that would make it more difficult if you're trying to use it for pain. How you adjust the dose that you're using is a little bit more tricky if it's got the variability in terms of how quickly it works and how long it stays around in your system. Anabolone or Sesamet, the oral pill that we have, that's the synthetic THC, same thing, it can take up to an hour and a half before it kicks in, and it can have effects that last for up to 12 hours. The spray is a little bit quicker because it's being absorbed in the mucosa in the mouth, and that's very vascular. There's lots of blood vessels in the mouth, so it can start to work more quickly. But there's variability there as well, particularly if people are swallowing it. So again, it makes it a little bit harder to adjust the dose and titrate compared to smoking. Potency of cannabis has changed over the years, and this particular graph only shows up to 2012, but we know that back in the 1980s, cannabis only had about 3% THC, and this graph is showing in 2012, the cannabis that they studied had about 12% THC. And we know now that there are products that are available that have over 30% THC in them, so quite a bit more potent. And anecdotally, we've heard people talk about having used cannabis many, many years ago and now trying it again recently, saying, holy smokes, it's much stronger than it used to be. So that's something to keep in mind as well, that it might cause more unwanted side effects just because of that higher THC content. And this is just showing you the potency of the different products available. So usually, you'll see up to around 30% is pretty common. But if you have things like the concentrated extracts, which are now available in Canada, and those are things like shatter, butter, wax, those can be upwards of 90% THC content. And so again, that would be quite a different experience than something that had 20% THC in it. So most of the licensed cannabis shops across the country, or I shouldn't say most, they all should be telling you what is in the product. And some of them will classify the products. This is Prince Edward Island, how they do it. They'll classify it based on mild, medium, or strong. And again, that's relating to the THC content. And you can see here that it will tell you what the concentration or what the constituents in terms of the THC and CBD are. So this is 17, no CBD or very minimal CBD. So the product should always be labeled with how much THC and or CBD it has in it. And this is just to show you an example from the AGLC here in Alberta. That is our licensed online dealer. This has got 500 to 800 milligrams per gram of THC. So very concentrated, very potent in terms of that THC content. So now speaking to the specific medical and therapeutic uses of cannabis, and this article, it's a great article in the New York Times that came out last year about CBD in particular, saying, you know, there's all these different things that are potential health issues that might be fixed or improved by the use of cannabis, and in particular CBD. We know right now that the studies are pretty early and pretty young in terms of the medical uses. So we have in Canada, the current indications for use would be refractory chemotherapy-induced nausea and vomiting. So that means that we've tried other products, other medications, and they're not working. So we may consider using cannabis to help if we've tried everything else. Chronic neuropathic pain or nerve pain, there's some evidence to suggest that cannabis might be helpful. Similarly for refractory end-of-life pain. So again, this is pain where we've tried other options and either those other options have not been working or they're causing unwanted side effects. We might be in a position then to consider using cannabis. And then spasticity in multiple sclerosis or spinal cord injury. There's some evidence to suggest that cannabis can help with those conditions as well. Where there's really limited or moderate evidence would be for appetite stimulation or weight gain, insomnia, difficulty sleeping, anxiety and depression, post-traumatic stress disorder. And these are all conditions and situations that are being looked at for potential use of cannabis. But still right now we don't have sufficient evidence to make the recommendation to be using this as standard care. And then right now there is no evidence to suggest that cannabis is an effective cancer treatment, although that's very much under study as well. So there's lots of different studies out there. This is a systematic review, and that means that they looked at a whole bunch of different studies to look at the medical uses of cannabis. And ultimately what they found in this systematic review is that there is improvement potentially in pain, and the authors in this paper stated about a 30% or greater improvement in pain with cannabinoids compared to placebo. And another systematic review found similarly that there's reasonable evidence that cannabinoids improve nausea and vomiting after chemotherapy, that they might improve spasticity, primarily in multiple sclerosis, but there's uncertainty about whether cannabinoids improve pain. But if they do, it seems to be that nerve pain or neuropathic pain, and the benefit's likely small. But this systematic review also found that adverse or unwanted side effects are very common. So we'd have to really weigh the benefits and risks and adverse effects when considering using medical cannabis. This is a Cochrane review looking at cannabinoids for nausea and vomiting. I think this is kind of funny because one of the authors' last name is Stoner, and that just seemed particularly hilarious to me when I found this paper. But this paper looked at 23 randomized controlled trials, and most of them were a crossover design, and it was adults going through chemotherapy. Sorry, I need to get my dog as he's making a bunch of noise. Here, buddy. Come here, Jasper. Yeah. And one thing to note about this Cochrane review is that most of the studies they included in this review involved trials that were conducted between 1975 and 1991. And so we know now that the antiemetics or anti-nausea medications that we have available are really quite good at controlling nausea and vomiting. And most of these studies included in this review did not include the newer antiemetic drugs, such as ondansetron or granisetron. And so in this study, they ultimately found that the trials were generally low quality, and overall, they felt that more research was needed. This was a study that involved nearly 3,000 patients with cancer, treated with medical cannabis, and it was between the years 2015 and 17. And overall, the authors found that cannabis was well tolerated and effective and safe for patients to help them cope with their malignancy-related symptoms. They considered it more of a palliative treatment. So again, it wasn't, it was more for symptom management. Here's just showing you the number of people that participated. And so at 2 years, they still had close to 1,500 people that they were able to follow. And this graph is showing the response to treatment. So you can see that really in the people who didn't really have much pain to begin with, they didn't really have a significant benefit in using cannabis. But these people here before treatment, you can see the blue graph is showing that they had pretty significant pain intensity. This is people who are rating their pain, 7, 8, 9 out of 10. And so initially, the blue graph is showing that, they had quite a bit of pain before using cannabis. After using cannabis, that was reduced. So those people having pain, it seemed to be effective. Similarly, you can see improvements in quality of life. So before treatment, you can see, these are the ratings for people's quality of life: very bad, bad, neither good nor bad, good, very good. And then after cannabis use was the orange graphs. People's quality of life seemed to improve quite significantly, and that was statistically significant. Now, the authors did say that people, the further they got out from their cancer treatment and their chemotherapy, that might have been the reason why their quality of life was going up. So it's difficult to say for sure how much of that was due to the cannabis. But they did note that people did have some improvement. They also found improvement in some of the other symptoms and side effects and things that people reported. So all of these different things: sleep problems, weakness, fatigue, digestion problems, anxiety and depression, nausea and vomiting, lack of appetite. They did see some improvements with that. And then they also saw some changes in people's medications. So some people were able to reduce the use of the other medications they were using to manage their symptoms. These are the Canadian guidelines that came out in 2018, showing the various different benefits associated with the different indications. So chronic pain, chemotherapy-induced nausea and vomiting, and spasticity. But again, drawing your attention to the quality of the evidence, again, being rated as very low or moderate, suggesting that we do need more research to be able to support the use of cannabis in these various different settings. Palliative came out with a paper late last year about medical cannabis use in palliative care, and they did say that there seems to be some potential effectiveness of cannabis for symptom control in adult palliative care patients, but it's ultimately unclear due to the lack of quality and quantity of the evidence. And this lack of evidence applies to the cannabis plant, its extracts and synthetic cannabinoids, and ultimately more research is needed. And you can understand why researching cannabis is not been particularly easy. For one, it wasn't legal. Recreational cannabis wasn't legal. Medicinal cannabis has been legal in Canada for many years, but you can appreciate that there's so many different types and roots and different things like that it makes it very difficult to study. I am happy to say that it is something that is being given quite a bit of attention in the Canadian research community and has received some significant funding as well. And so I'm hopeful that we'll get some more good quality studies and data to be able to inform our practice going forward. Again, there's this potential question that comes up all the time as to, how or can cannabis cure cancer, or does it have any role in curing cancer or treating or managing cancer at all? And Donald Abrams is a medical oncologist from the States, and he's done a lot of work with cannabis over the years, and particularly in the context of cancer. We know that definitely there is an implication or association between cannabis and all these different pathways involved in carcinogenesis and anti-cancer pathways and things like that. So the tricky thing is, I think that we don't know for sure if cannabis is pro-cancer or anti-cancer, and it probably varies depending on the type of cancer, and all these different pathways are very complex, as you can appreciate. A number of different studies are showing that there are changes in the receptors with particular types of cancer, so this may represent a potential therapeutic target for us if we know that these receptors are increased. But again, we don't know for sure when we muck around with those receptors what the consequences will be. And so it's really important to do more research. And I will say that a lot of the studies to date have been in vitro, meaning not done they're done in lab settings outside of the body. And the ones that are in vivo, meaning in the body, are usually murine models, so mice or rats. So we don't have a lot of human studies yet to show the impact of cannabinoids on cancer. And Don Abrams, the medical oncologist I was just referring to, said in that paper that was released earlier this year that sometimes the increased cannabinoid receptor expression is associated with improved outcomes, and other times it's associated with poorer prognosis. His suggestion is that we should be doing molecular testing of tumors to consider looking at CB1 and CB2 receptor expression, and that could be, again, a potential target for therapeutic intervention. But as of yet, this is still very much in its infancy, so we definitely at this point would say that there isn't enough evidence to say that cannabis can cure cancer, but it is under research throughout the world. Now, cannabis and COVID, another potential therapeutic target, and this there's lots of comments about this in the media in the past few months as well. So we know the pathogenesis, or we're learning about the pathogenesis of COVID, that there is a lot of I guess a big role for inflammation. We know that cannabis can have anti-inflammatory properties. So this is just, you're looking at the normal state here and the disease state here, and this would be in a lung. And so all the inflammatory mediators, and you may have heard them talk about cytokine storm in people towards kind of the more serious stages of COVID, that all these inflammatory mediators can be released. And so is there a potential role for cannabis if it's got anti-inflammatory properties? This diagram or illustration is also kind of showing the pathogenic phases of COVID as well. So showing, the initial infection, the early infection. You would not want to be suppressing the immune system here necessarily because you want the body to fight it off. But we know that as you get into that hyper-inflammatory stage, that's where all those cytokines are being released, and that's the cytokine storm, and that's what we know can be very deadly. That is where we're seeing things like dexamethasone, which is a steroid that is an anti-inflammatory, has anti-inflammatory properties. It does seem to be effective as a treatment in that inflammatory phase for some patients. Again, that evidence is very preliminary, but does seem to be helpful in that stage. So again, the question would be, is there a role for cannabinoids to be added to antiviral therapies to reduce lung inflammation? This is just showing all the potential ways that CBD and THC might influence the inflammatory response potentially in the situation of somebody with SARS-CoV-2 infection. Right now, we can only say that more research is needed in this area. We can't make any other recommendations at this time. But again, if it was going to be a therapeutic option, it probably would be later in the course of the infection rather than early on, and should not be used as a preventative measure, therefore. So keeping that in mind as well. So there's lots of different practical and safety considerations, costs, the side effects, drug-drug interactions, legal issues, and things like that. So just to show you the different costs of these things. So Navalone costs about $94 to $305 a month, depending on how much you're taking it and what dose. The nabiximols spray is also quite expensive, and depending how much you use, can be up to $900 a month. And then dried medical cannabis varies depending on the province you live in, but can also be quite costly. And most insurance companies right now are not covering medical cannabis. I think they're starting to look at it, but the paperwork can be very onerous. You can, however, claim medical cannabis as a medical expense on your tax return, but you'd need to have all the documentation in place in terms of having a prescription and things like that. Just showing across the country the variability in terms of the cost of cannabis. So this is per gram, so it can be quite expensive up in the territories. And Quebec seems to have a relatively lower price compared to the rest of the country. And then thinking about the risk of harm. So risk of harm not only to the person, but also to others. And so things like, you know, when we're talking about risk to others, we're thinking about, you know, what happens if someone drives while under the influence of cannabis? What about the impact on the relationships? If there's cannabis use disorder or cannabis is interfering with how the person is functioning in the relationship. So there can be a number of different costs and harms. This is based on a study, I shouldn't say study, it was a group of experts that came together and kind of ranked the potential for harm of the various different drugs. So you can see alcohol is kind of top of that chart, and cannabis was felt to be not necessarily as harmful as alcohol or some of the other recreational or illicit drugs. So again, thinking about harm, all the different things that may be potential harms. This graph or chart is showing, you know, looking at the quality of the evidence and things that we know for sure, there can be associations between cannabis use. Each of these dots represents a systematic review. So again, we're not seeing that there's necessarily an association between cannabis use and lung cancer, but there can be an association between chronic cannabis use and a particular type of testicular cancer. And then, you know, there's all these different potential harms that may arise. Again, making the point that the quality of the evidence is not necessarily super strong or very good, and that more research is needed. We do know that, you know, cannabis can cause problems if people have history of schizophrenia or psychosis, if there's cardiac issues, there can be concerns. If there's history of substance use disorder of any kind, these would be situations where we would recommend that cannabis not be used at all. So obviously pregnancy and lactation, and then precautions. So using motor vehicles, we know that cannabis can cause impairment in executive functioning, operating industrial equipment, using with other drugs that might be sedating, low blood pressure, heavy tobacco smoking, and then certain types of medication because there can be interactions. We know this is data from CIHI that hospitalizations have gone up, and in Calgary we know they've gone up since legalization, and that's been due to psychiatric concerns, potential inadvertent, not overdose necessarily, because we know that cannabis has not really been related with significant overdoses causing death, but there can be overdose situations that cause unwanted effects. And we know there's something called cannabis hyperemesis syndrome, where people can, they throw up and feel very unwell, and that's been seen since legalization as well. Dependence and addiction, again, the risk of addiction is estimated to be around 9%. That increases to about 1 in 6 if people start using cannabis as teenagers, increases to 25 to 50% in people who use cannabis daily. And we know that there can be withdrawal symptoms, irritability, difficulty sleeping, dysphoria, craving, anxiety in people who have developed dependence on cannabis. In addition, we know that there can be infectious risks. So there's lots of different contaminants that can be in cannabis, the plant-based cannabis. So heavy metals, pesticides, microbes, insects, so spider mites and aphids, mildew, mold, bacterial contaminants like Enterococcus, Salmonella, Enterobacter, and fungus like Aspergillus, Fusarium, or Penicillium. We've seen this in people going through immunosuppressive therapies, and particularly this one report was on somebody, I believe, who went through bone marrow transplant and ended up with a bad fungal infection. Driving, again, as I mentioned, we know that cannabis use can decrease executive functioning, and there's a relationship between the blood THC concentration and performance in controlled driving simulation studies. And so we recommend that people arrange for rides to and from their appointments if they're using cannabis as a medical treatment. Similarly, if you're going to start using cannabis as a medical treatment, it may really impact your ability to travel. Now, travel right now we know is restricted because of COVID, but when we do have the ability to travel again, it's really important to note that even if you have a medical prescription for medical cannabis, it's not legal to take cannabis across the Canadian border. Even if you're going to a state or area where cannabis has been decriminalized, so if you're going to Colorado, for example, it's still illegal to take cannabis across the border. And this can result in people being banned for life from going to the US. Drug-drug interactions, I'm going to go through this pretty quickly, but we know that there can be interactions between cannabis. It can be, even if it's smoked or ingested or taken orally. And this is important for people taking lots of different medications. So this would be something, if you're going to start using cannabis, I would review this with a pharmacist or your physician, because there can be significant interactions with a number of different medications. And this is one where a patient was using something called tacrolimus, similar to cyclosporin, and his tacrolimus levels were impacted because he was using cannabis. We know this also in a particular type of medication we're using for cancer. It's an immuno-oncology type of medication where it uses the body's immune system. And because we know that cannabis can interfere with immune function, and particularly can act as an anti-inflammatory, this particular study found that there was reduced response rates to nivolumab, this medication. It didn't impact overall survival for the patients in this study, but they did have poorer response compared to people who are not using cannabis. So again, something to make sure your medical team knows if you do start to use cannabis. So what's next? I think I've made the case that we need more research. By the way, I do have a Dachshund, and this is not him. I took this picture from the internet, but we do need more research. We need to know what the impact of the CBD and THC ratio is on pain and different symptoms. You know, should we be using something with more CBD or less CBD and more THC? Right now, the evidence would suggest that it's probably best to use something with CBD and minimal THC, particularly if you haven't used cannabis before. THC seems to be more associated with the psychoactive side effects, the euphoria, being high, and that kind of thing. And CBD is not as associated with those kinds of effects. But at the very least, find something that has a little bit of CBD in it, because that seems to abrogate or mitigate or offset the impact of the THC in terms of the unwanted side effects. So we need to know more about that. We need to know more about the other cannabinoids and what the role of those other cannabinoids is in symptom management. What's the dosing right now? We don't really have any good recommendations in terms of how much should we be using for various different indications. How should people be using it? We know that smoking and vaping is probably not the best. We know there are challenges with ingesting in terms of delayed onset and variability in absorption and metabolizing. So that can be difficult with oral routes or ingesting. And then, you know, finding ways to mitigate the risks in terms of all those harms that I was mentioning. So again, you know, we know that cannabis wouldn't really be considered a first-line therapeutic option, but refractory symptoms, particularly for chemotherapy-induced nausea and vomiting or nerve pain, there might be a role there. Also for spasticity with MS or spinal cord injury, there may be a role there. And it's important to really know what that product contains if you're taking it, how much THC and or CBD is in the product. Thinking again about the different routes of admin, not smoking or vaping probably, but if you're ingesting, making sure you have a plan in terms of, you know, what the next 12 to 24 hours might look like, because it can take that long for the cannabis to get out of your system. Keeping track of the different adverse effects with the symptom diary or journal can be helpful. And always making sure to store cannabis products out of the reach of children and pets, because there can be significant adverse effects for children and pets if they are to take cannabis or use cannabis. There's lots of different resources that exist, and again, David Casseret and Donald Abrams in the States have done a lot of work on cannabis, and particularly medical cannabis, and there's lots of different resources that Health Canada has available as well, and that is all that I wanted to say about all of that. So happy to answer any questions, or if people have questions, I'm also happy for you to email me, and I'll just put my contact info back up again here. And if you have questions, again, feel free to email me. And I hope that's showing again there, Fiona.
Yes. Yes. Thank you so much, Reanne, for that information-packed presentation. I'd written down a few questions that I had, but you answered most of them. One I had is just about whether there's any research going on about cannabis use and menopause symptoms.
Oh, that's interesting. I haven't seen anything yet, but there are studies that are coming out all the time. So that would be interesting. Again, I don't know what the mechanism would be specifically, but in terms of menopause symptoms, are you thinking like hot flashes?
Yeah, insomnia, anxiety, those things that are attributed to menopause.
Yeah. So I would see more of a role with the anxiety and the insomnia. I can tell you there are also, as I mentioned, there are lubricants and different products that contain CBD and THC that some people are looking at intravaginal use to see if that helps with any of the changes in the vaginal tissues after menopause, because the loss of estrogen can lead to significant vaginal dryness and stenosis and painful intercourse and things like that. So that's something that is being looked at. And we don't have evidence right now to say that it works necessarily or not, but just to make the point that studies are ongoing, and hopefully we'll get some answers soon.
Yeah, it's amazing to see all of the research that's happening and how many unanswered questions there are right now, I guess.
Yeah, and you can appreciate that it's difficult because it's so complicated. The physiology of cannabis, we're just starting to understand. And again, all the different roots and the concentrations of THC and CBD. And so we would need to make sure that we had something really consistent in terms of studying the effects. And, that work is being done, definitely. And, hopefully we'll get results and answers soon so we can provide more definitive guidance to patients on how to use cannabis safely.
Along the same lines, I guess we have a question here. What is the best strain for pain when making an edible?
Yeah, so again, I would focus as much on the strain, but I would focus on the THC and CBD content. And so again, the evidence is suggesting that products containing more CBD may be more beneficial and not as associated with unwanted side effects. So looking at the CBD content, I would look for something that's more heavy on the CBD content, and try to get something with less THC content. And again, this would be more so for nerve type pain or neuropathic pain, because that's really right now where the bulk of the evidence is suggesting there would be the most benefit, is in that nerve type pain. And so, yeah, so it's more, and you could speak to somebody in one of the licensed retail outlets about getting something that has more CBD in it, and they'd be able to direct you to something containing more CBD. You can also email me and I can provide you more information specifically on that. But those licensed outlets, they should be able to give you more direction on finding something that's got more CBD rather than THC.
Okay, and another question here is, can you explain a bit more about the effect on the immune system and cannabis?
Yeah, so it's still very much evolving in terms of how cannabis affects the immune system, but we do know that cannabis has anti-inflammatory type properties, and so it can suppress immune response. So again, and this is why we think it might be beneficial for some types of pain and things like that, is because it seems to suppress inflammation specifically. And so again, this is, we're thinking about COVID infection, and that you wouldn't want to suppress the immune system, or you wouldn't want to tamp down that response in early infection. Later in infection, when that inflammatory response is kind of going haywire, there may be a potential role to suppress it at that point. So again, we don't know a huge amount about how this works specifically. And again, it'd be great to have studies to say, CBD containing products are not as associated with certain side effects or outcomes, and THC are associated or not associated with different outcomes. We just don't know the ins and outs of all of that yet. It's still quite complicated. But overall, we know that there can be anti-inflammatory properties with cannabis, and that seems to be a fairly widely accepted outcome of cannabis use in terms of how it affects the immune system.
Mm-hmm. And someone's asked, what exactly is the effect of low blood pressure and cannabis?
That's a good question. I haven't seen that clinically. I think the concern would be if you're using cannabis, like some of the other medications that can cause sedation or make you feel kind of drowsy. If you have low blood pressure, you might already be prone to feeling kind of faint or dizzy, and potentially that may exacerbate it or make it worse. But that's a good question. I don't know for sure, and I'd have to look into that association. I haven't seen that be a particular huge concern clinically necessarily, and I haven't seen that come out in a lot of different papers. That was that one particular resource that mentioned that. So that would be something I would check with your doctor more about. But yeah, I've seen more concern with cardiac issues overall, and again, particularly when people are using higher doses of THC. We worry about potential cardiac complications. There was a case of a man who ingested a good portion of a lollipop containing a huge amount of THC, and I believe he had a heart attack, and they thought it was possibly associated with the cannabis use, and he'd never used cannabis before, so was a naive user to it. And again, the exact way that it works and causes cardiac issues, I think, is still very much unknown. I know I gave a talk in January for Palliative Grand Rounds, and we had a cardiologist in the audience, and he was speaking about it a little bit, saying that it's still, we know that there's an association between cannabis use and potential risk of cardiac complications. We don't know exactly the mechanisms involved thus far.
Okay. Well, thank you for that. That seems to be it for our questions right now. So as I mentioned, we will be posting the webinar recording on our website, and Reanne's kindly offered to answer any other questions you want to send her by email. And I just want to, again, thank you, Reanne, for taking the time out today to share this information with us. We really appreciate it. And I want to encourage others on the line just to check our website for news of other webinars we're hosting in the month of October and November. Thank you very much, everyone, and enjoy the rest of your day.
Thanks so much, everyone. Thanks for being here, and thanks for having me, Fiona. Take care.
Oh, you're welcome. Thank you. Bye-bye.